السلام عليكم جميعا. First, thank you for the organizing and the scientific committee to invite me for give this talk, our treatment for bacteremia. And I have to make a big disclosure. I'm not choosing this topic. They are choosing me to present this topic every year. So I'm not the person, okay? But although this year we presented with a little bit a new twist. So inshallah, hopefully you're gonna enjoy it. Starting with case 1. So we have a 55-year-old gentleman who have a comorbidity, presented with the right flank pain, systemic symptoms, both urine and blood grew E. coli pan-susceptible. He was febrile, blood pressure was borderline initially, tachypnic, but sitting well on room air, and his white count shows in the lab leukocytosis with high elevated creatinine from his baseline of 60. So he have an AKI. And also the CT shows right side hydronephrosis with dilated ureter. He was started initially on ceftriaxone. Of course, this patient doesn't exist in our hospital. يعني started empirically on ceftriaxone just for the sake of the presentation. And on day 3, he is improved, afebrile, white count is improving, creatinine is trending down, it's almost back to normal. So it's within the normal range, 90, and he's tolerating oral and asking for discharge. So what you will do? A, how many for A? And raise hand, show hand. Anyone for A? No one? Anyone for B? Discharge and switch to oral for the remaining duration. How many for B? 1, يعني 10 maybe. Like C, continue on ceftriaxone as the remaining. Okay, so B and some silence. Okay, so case 2, another lady with a comorbidity presented with pain and tenderness at the site of the peripheral cannula that was removed 1 week ago because she was admitted and treated for complicated UTI. She was also febrile, blood pressure was borderline, tachypnic, but sitting well on room air, and she have a normal cardiovascular exam, equal bilateral breath sound, and also she had tenderness with well-demarcated swelling at the site of the peripheral cannula on the right dorsum of the hand. Lab shows leukocytosis, creatinine was 90, slightly above the baseline, but at base, يعني within the normal range, I would say. CRP was 200, and blood pressure was taken. Patient started empirically on IV vancomycin, and blood culture was back with gram-positive clusters, and it finalized as MRSA. And after 72 hours, fever subside, blood pressure normalized, redness and pain is decreasing, and she's doing better. Her transthoracic echo was negative for vegetation. Chest X-ray was normal, and the repeated blood culture that was drawn second day on the admission, it's finalized, no growth. On day 7, she's asking for discharge. So let's see. How many for A? Continue vancomycin IV for her for the rest of the duration? No. How many for B? Discharge the patient on IV vancomycin as pump infusion. Daptomycin. D. Switch to Bactrim, linezolid, and discharge the patient, or linezolid. Okay, good. And some silence also. But at least the most choose the oral switch. So I think you are not alone with this variability, because actually this is a survey that was done to assess how the variability of the physician to switch to oral in gram-negative bacteremia. And as you can see, there's a pointer, I'm not sure. But anyway, the red shade of the bar represents the oral step down, and the blue shade represents the physician who preferred to continue for the whole duration on IV. Most of the responder were ID physician and ID clinical pharmacist, and most of the infection that they were reported is that. And that tells us that this step down therapy is still a clinical equipoise. And to solve this clinical equipoise, we need 17 years. So according to this research, we take an average of 17 years to actually take a new data from the bench to the bedside to research to apply it to the practice. So we need 17 years. So let's see where we are in this 17 years. Are we close or still far away from this 17 years to apply this concept of early oral switch? So this is my outline for the talk, why we need IV for severe infection. And from that, we'll see if there's any difference between ICU and non-ICU patient in that concept. And also, sorry, and also what are the antibiotics that consider high bioavailable? And from that, we'll see, can we switch from day one, not to wait till the end, or after a couple of days? And also step by step toward the early oral switch bacteremia, going through the criteria, mortality, limitation and advantage, and how to implement it in clinical practice, and then summary. So why we need IV for severe infection? As you can see, it's complicated when it comes to the patient with ICU. A lot of pharmacokinetic, pharmacodynamic changes that actually make the GI absorption unable. And for example, if you look at here, if you have a patient with disturbed distribution like fluid shift, fluid overload patient, you need actually to adjust the doses for a couple of antibiotics like meropenem, gentamicin, ceftazidime. But what about non-ICU patients? Because actually those patients we are considered for early oral switch are more for stable patient, non-ICU patient. Do we still need for IV antibiotic from day one? So Expo antibiotic, it's a prospective study that was done in multi-center, and the primary endpoint to determine actually whether the acute phase of the infection affect the antibiotic exposure after the oral administration. So they had two intervention groups, Group A and Group B. Both groups receive IV antibiotic therapy empirically for the indication, as per guideline. But Group A received extra dose of amoxicillin on day one when they were febrile and admitted first to the hospital, and they drew 4 blood samples. Group B, they received 1 extra dose of ciprofloxacin plus the IV antibiotic that's running, and they drew blood sample. And they have a second phase where they actually, when the patient is afebrile and clinically stable, so they receive also, Group A receive another extra dose of 1 dose of amoxicillin, and Group B also receive another blood group of another single dose of ciprofloxacin. Then they also drew a blood sample to check the antibiotic level. And what's surprisingly, that the AUC and the Cmax was comparable between both groups when they were febrile and afebrile, with same ratio for both AUC and Cmax for both groups. Also the, sorry. Also the probability of the target attended, which is the PTA for both amoxicillin and ciprofloxacin, was the same, comparable between patients who were febrile and non-ICU patients who were febrile, and also when they were afebrile, and concluding actually that, that for acute phase of infection for non-ICU patient, you can actually start oral therapy from day one. You don't need to wait for 3 days for them to start to switch them to IV, from IV to oral. I will actually mention another study that actually applied that and augmented a little bit. So what about the antibiotic would consider high bioavailability? So it's not only about bioavailability, it's about appropriate dosing, appropriate pharmacokinetic, appropriate pharmacodynamic. So it's different, it's a factor that you collect together to reach this or increase the bioavailability of the medication. So for this study, it's a systemic review and meta-analysis for oral fluoroquinolone, Bacterem, and beta-lactam to use as a step-down therapy. They assess 8 retrospective studies and also including complicated and uncomplicated patient, variable source, but mainly UTI was the majority. As you can see here, for all-cause mortality, when it comes to all those three antibiotic, there was no comparable change. It were all comparable. So there is no mortality difference between all three groups. But when they break it down to overall recurrence of the infection and recurrence of the bacteremia, they were more favoring the oral fluoroquinolone over the beta-lactam, because they were increased twofold of mortality risk. And those with this, they conclude actually, or possible explanation of this finding, that there was more frequent dosing of beta-lactam, which actually make them maybe less favorable for the patient and decrease the compliance. And also, the suboptimal dose of the oral beta-lactam was noticed in around 30% of the patient, where the suboptimal dosing for fluoroquinolone and Bacterem was only in 3.4% of this patient. This is another study, actually. It's a randomized study forced to assess if we can use oral fosfomycin as a step-down therapy for patients with gram-negative bacteremia. So they screened 143 patients. They randomized them into 70 patients who received IV vancomycin. I'm sorry, I cannot see the pointer, but I'm hopefully you are following. And 70 patients received either ceftriaxone or meropenem. The step-down part was not randomly assigned. It was based on physician preference. So all the patients with IV fosfomycin was stepped down to fosfomycin orally, and for patients who were switched to or randomly assigned to ceftriaxone and meropenem was assigned to either or switched to cefuroxime, augmentin, Bacterem, Cipro, and one of fosfomycin. So they had a total of 61 patients switched to oral vancomycin and 74 to another, 47, sorry, to another antibiotic. And as you can see here from the analysis, their primary endpoint was to see the clinical and microbiological cure test at day 5 or 7 from the switch. And they saw that actually in oral fosfomycin group, they had, I would say, less clinical cure and microbiological cure, and that was attributed to the decrease in the microbiological eradication for those groups that were switched to oral fosfomycin compared with the other antibiotic. So, and also the risk of the relapse was higher in oral fosfomycin, although it's not statistically significant. So fosfomycin as an oral option or step down is still not yet. Can we switch for, okay, and this brings us to, can we switch from day 1? So this is the study that Augment Expo. It's a real world study that actually check if we can actually step down to to patients from bloodstream infection from the emergency itself. You don't need to admit them to the hospital at all, from the emergency. So they had 2 groups, case and match control. So bacteremic febrile patient, the first group. The second group is non-bacteremic febrile patient, both present at the same time in the ER for the same duration. Then actually, after applying the criteria of low eligibility risk, they actually decide to discharge them on oral antibiotic therapy. And as you can see, their primary endpoint is unplanned consultation within 30 days from that discharge, and the consultation was comparable between the 2 groups and not statistically significant. When it comes to the secondary endpoint, the 14 days mortality, it's also comparable, 0-0. And when it comes to the 90 days mortality, I would say it's more favorable of the group because they are infected. The other group, they are febrile for another reason. That's why we have a significant 90 days mortality, significant p-value in a form of blood bacteremia. And this actually might change actually the current practice that we have to admit the patient to the hospital for IV for a couple of days and challenge that concept, where we can actually discharge them from the ER if they have low occult bacteremia. So step by step for early oral switch, going through the criteria, mortality, limitation and advantage, and how to implement it. The criteria, I'm sure you guys all know it. If you attend last year, I already posted. So it's the same criteria. So favoring oral, clinic, and hemodynamically stable, low risk bacteremia, no suspicion of complication, and etc. For favoring IV, I just add 8 and 9 because actually those population were underrepresented in the oral switch group. So it's a minority and also underrepresented in the trials, I would say. In the retrospective, they're presented, but in the trial, they are underrepresented. So I would say favoring IV for them. This is defining the clinical stability, basically afebrile, improving the vital sign, improving the labs. What about the mortality? So this meta-analysis included all the 10 RCTs that presented over the decade for talking about gram-positive and gram-negative bacteremia, and they actually conclude that there is actually decreased the risk favoring, that there is no risk difference when it comes to long treatment success from IV to oral, with plus 7% favoring early switch to oral. But there is 2 trials that was published earlier this year that's not included in our in that meta-analysis, and it's worth to mention it. The first one, it's by Dr. Ali Amrani, so I'm proud of it because it's a Gulf trial. So it's a switch SOAP. It's a switch trial, open label randomized clinical trial, 174 patients, 85 to oral group, 85 to IV group, and 89 to the oral group. So they set a non-inferiority margin of 10%, and actually most of the source were UTI caused by E. coli and Klebsiella pneumonia. It's worth to mention that the PO switch in that trial was mostly beta-lactam. And the treatment failure that was documented here, that actually there was no treatment failure, but when they said, when they checked for IV group or oral group with the inferiority margin of 9%, so it's less than the non-inferiority margin. When it comes to the 90 days all-cause mortality, it's the same, less than the non-inferiority of 8%, and the same for the additional antimicrobial therapy and microbiologic relapse. And those are actually the 18 patients that had a treatment failure in the oral group. They received variable antibiotics, so you cannot attribute it to specific antibiotic. Sabato, it's published also this year. We talked about it last year, but this year it's available in full form. So they actually check for early oral switch for Staph aureus bacteremia, mainly MSSA, and 5% of MRSA. And they check for the early oral switch was to Bacterem primarily, or secondary to clindamycin or linezolid for MSSA and MRSA, and oral. And primary outcome was the 90 days mortality complication, which was comparable between the 2 groups and meeting the non-inferiority margin. The secondary outcome was decreased the length of stay in favor of early oral switch by 4 days. The 90 days mortality was also comparable and not statistically significant. The risk of complication was, of course, from the IV was more in the IV group, and C. diff was comparable. So limitation and advantage. Advantage for early oral switch, it's improved the patient comfort, it's reduced the incidence of IV-related infection, reduced the length of stay, reduced the cost, reduced the nurse load, reduced the drug cost. How much I should mention to say the benefit of that. But also there is limitation because actually you have to practice this judgment and applying those criteria to see if your patient fit the criteria or not. And also the availability of the drug, it's challenging with the MDR that we are seeing every day. And also the heterogeneity the presence of the prosthetic devices, which is unclear if those category, can we switch them to oral or not? And also the optimized duration, to be honest, after the switch is not fully understood. So how to implement it? 3 more studies and we're done. Okay, so in this study, the nice about it that actually they went and checked the retrospective for all urinary and urinary source of gram-negative bacteremia. They included ICU patients, they included immunocompromised patients, they included patients with MDR bacteria, they included patients who have plant-susceptible bacteria, and they reviewed those data to see can we do the early, how was the early oral switch for those patients. So the main infection was urinary tract infection, and Cipro was the most common antibiotic used for early oral switch. And as you can see, their primary endpoint was the treatment failure, which was comparable between the IV group and the IVPO group, including those patients that we mentioned. Okay, but when they went down and see the multivariable, they did a multivariant analysis to see what's the factor that led to this treatment failure, which was the relapse of 30% was mostly the attributed cause of the treatment failure. And the attributed factor for that relapse was for both IV and IV oral switch. Presence of metastatic solid cancer with increased odds of 4%, HIV infection less than 200, which increased the odds of 8%, and QSOFA score more than 2, which increased the odds for 2%. For multi-drug resistant and respiratory tract infection, it was mainly increased the odds of infection for oral switch group, not for the IV group. Another study that actually see if the current practice of timing and the frequency of the antibiotic will change the time switching. So as you can see, this is a 4,500 episode of gram-negative bacteremia, and that was, they collect the data from 24 hospitals in US. And most of the infection was secondary to UTI. E. coli was the most common bacteria reported. Ciprofloxacin also, again, was the most common antibiotic used. And they assess how much those patients were ready to be switched to oral and compare it with the time of the early oral switch. And surprisingly, they found that actually 90% of the patients achieved clinical stability by day 5, but only 43% of those patients that included in that study were switched at day 5, which actually give us that there is actually a room for earlier oral switch, than we can do it as early as we achieving the clinical stability of the patient. But when they went down and see why those patients were not switched, they saw that they were immunosuppressed, so the physician was not comfortable, and also they were having ICU admission during that stay, fever and hypotension, renal replacement, no source control, although they were achieving earlier clinical stability, but because of those comorbidities, they were not switched early. The last one is the real-world effectiveness of IV antibiotic step down to see if how is the bioavailability of a different medication when it applied to gram-negative bacteremia. So they had 759 patients. Oral fluoroquinolone were distributed either to receive oral fluoroquinolone, Bacterem, or beta-lactam after receiving a full course of, or I will say, a couple of days of IV beta-lactam for all the groups. Then they divided the beta-lactam to either high bioavailable beta-lactam or low bioavailable beta-lactam. Those are the antibiotics that they were used or for the switch. And again, E. coli, Klebsiella species that were mostly reported. ESBL were minority in this study. It's only 23 species. The primary outcome was the recurrence of the 3 days through the index of day 60. And as you can see, the dot lines, it's already explained down, but for high bioavailable beta-lactam, there was increased the hazard of actually relapse and mortality for those group who were switched to high beta-lactam, high bioavailable beta-lactam, with increased hazard of 3.8%, compared with the IV beta-lactam, which is standard of care, fluoroquinolone and Bacterem, which is presented the two lines, it was actually comparable to the IV group. And when they break it down to the duration to see if switch for those patients before, or I will say total duration for the treatment after the switch for 10 days or more than 10 days, which one is preferable for those patients with, this study actually compared complicated UTI. So they include patient with hydronephrosis, they included patient with AKI, they included patient with renal stones. So they wanted to see if 10 days duration is enough or not. So when they break it down by duration, they found that for short course IV duration of beta-lactam of 10 days, it was comparable with good mortality benefit with low mortality, with no mortality compared with long duration of fluoroquinolone more than 10 days, and actually longer duration of Bacterem step-down therapy. And for those who receive high dose or high bioavailable beta-lactam, they had either for short duration, long duration, they had treatment failure. And also for short duration of Bacterem, also there was treatment failure with increasing a lot of 4, 3, and 5% fold. So this is our summary, if I have time. I still have time? Okay, good. Right. So this is my summary and my recommendation, but I want to actually move to personalized medicine, which is a very dear topic to my heart. Okay, and actually this early order switch is actually presenting how we can do personalized medicine to our patient, because it's actually a collection of the focus, species, and microbiological etiology together to have a selected appropriate antibiotic option for our patient. And from moving from being reflexive medicine to have a predictive medicine, where we can actually risk stratify our patients, see who are the low risk, who are the high risk, and actually give them the benefit of the doubt and receiving the appropriate therapy that they need. With this, I conclude. So if you vote yes for early oral switch, I want to see a hand. Okay, that's better than initially. If you vote no, okay. You vote yes for me coming next year to say the same topic? Okay, so thank you so much.